and welcome to this breakout session on enabling participation in research. I'm Tom Barlow, a member of the Chief Scientist Office team, and I'm really pleased to be co-chairing this session with Zosia Miedzybrodzka from the University of Aberdeen, who's going to tell you about some of her own experiences about enabling participation in research. But before that, I want to thank Edge, who have kindly sponsored this session. And I also want to emphasise how important wide and broad patient and public participation in research is to CSO. So I'm really delighted that the presentations today will cover various aspects of that and engaging different people. So I really hope you enjoy the session. We are overrunning. We'll try and get us back on the time so you can have some time for a sandwich. And now I'll hand over to Zosia. Thanks.
Hi there. Yes, so I was asked to just give you some reflections from some work that you might have seen in the press earlier this year. I had a family that I looked after in my NHS genetics clinic in Orkney, and I started looking after them when I was a registrar, which was quite a while ago. And we started to do family-based risk assessment for familial breast cancer and ovarian cancer. And there just seemed to be more people coming to that genetics clinic in Orkney than there should have been. And over the years, genetic testing for BRCA1 and 2 became standard of care. Then we started to see this gene alteration in different family groups that were coming to the clinic. And over time, the status of this variant changed from being a variant of uncertain significance to being pathogenic. And we then had to go back and recontact everybody we'd met and start to offer diagnostic testing for this variant to these various family groups. And because I was doing all that work myself with one named genetic counsellor, we were slowly able to piece together the fact that it was pretty obvious, really, because it was the same rare variant. We were dealing with one huge family, as we maybe would have expected in Orkney. And over time, we built up a family tree which had hundreds and hundreds of people on it and shared individuals with breast and ovarian cancer, all linked by this one variant. In order to publish that, I wanted to have a population-based number because that was what was stopping me being able to say this mattered beyond the family that we knew. And then I heard about Jim Wilson getting exome sequence data from his ORCIDES cohort study. And as part of that, we were able to then go in and mine the data. And I said to Jim, tell me the population prevalence of this variant. And he could look it up. And what we found was that 1% of Arcadian participants in that study of 2,000 people had this variant, which is 10 times how common BRCA1 variants are supposed to be in the population. That's cost effective. In NHS England, if you have a grandparent who's Jewish, you have a lower chance of getting a BRCA1 and 2 mutation, but you can get a test as standard care. So this has the imperative then for making that test available. So what this became was a story of taking that clinic and NHS lab finding, bringing that together with the, as I put it, the cohorts, the epidemiology, the genetics, but also genealogy, with phenomenal genealogy and informatics that's let us estimate the prevalence of that and actually other variants too, which is set for another talk. And then Jim and I took that finding to the community in Westray, where what we proved was that this variant not only came from Orkney, but we were able to pinpoint it through ancestors back to a common ancestor in 16th century Westray. And that meant then that we could pinpoint not just of the 1% of Arcadians, but those of Westray ancestry would be those at highest risk. So it made sense to tell that community before you drop that bombshell. So we announced the paper in Westray with the BBC, with STV, and after 1.5 million hits on the BBC, after it went to 14 news networks worldwide, and I got a clipping from New Zealand, it kind of went to the community. The Westry community then stood up and said, hang on, we need this testing, we need it now, we will pay. We started screening in Westry in July. We've had a phenomenal response. It's only 74 people who've taken part. That is about 20% of the adult population of Westry, which is really, really high for that kind of population, if you want it, type of offer. Done with saliva, box of kits at the GP surgery in the Westry Development Trust, postal submission, postal send back result. And it's been highly successful. So easy, but so difficult to take it to the next stage, but that's what I'm working on. But it was all about engagement with the community, talking to the community. And so, yeah, so for me, what we've got in Scotland is the 3 C's. It's clinics, cohorts, and community. And if we can pull that together, we can do things that people in the rest of the world can't do. We think it's fairly straightforward and basic and just something we should be doing. Other people think it's amazing. So, just for me, huge thanks to enormous numbers of people who made this happen, especially Jim and the Westry community. And for those of you who don't know, that's the Westry wife, and she's 5,000 years old. She's the oldest human figure, I think, in Britain. Thank you.
Okay, thanks very much. So I think in the interest of time, we'll not go to questions. Yeah, we can. Okay, over to you. Thank you.
Thank you. So yeah, first off, thank you very much to everyone who has managed to come together last minute to bring slides and allow me to be attending virtually and presenting virtually to you. One of the chores of living in very rural Aberdeenshire. Beautiful, not great weather-wise. So yeah, here I'm going to talk to you today about the STRIDE project. I'm going to give you a bit of sort of background as to how we got to the STRIDE project, with the overarching message of questioning yourself as to who stands to benefit from the results of your trial. Because I think a lot of the time we go into trials kind of with the aim that we know we need to recruit diversely, but it's very difficult. We know trial recruitment is hard, retention is harder. So yeah, trying to give you some tips on that. So just to lower the tone and make things a bit sad to begin with. So who are the underserved? Who's underserved by research? So deep breath. Everyone who is not financially stable, but not in full-time employment, well-educated, middle class, digitally literate, city living, not pregnant, not disabled, non-smoking, cisgendered, straight, English-speaking, white, but not from a white minority man, between the ages of 19 and 74, with no mental health conditions, learning disabilities or cognitive impairments, but who does attend regular medical appointments and is of a healthy weight. So if you are not any of those things, you are currently being underserved by health research. And that's the sort of shocking part of all of the research that we do. So we know that trial participants, with this in mind, lack diversity in terms of ethnicity. So this project focused... I hear something? So this project focused primarily on ethnicity, but a lot of the learnings that we have will span various underserved communities to ensure that we can try and make research more diverse. We know then that if you don't include people of various ethnicities in your trials, the results will not serve the communities that they should do. So we will sort of feed health inequalities. So what we need to do here is do something about it. So I come with a solution, which is at least something. So the include frameworks were, we started with the ethnicity framework, and this was led by Professor Sean Treweek, who is based at the University of Aberdeen. I worked there until very recently and contributed to that ethnicity framework. Vicky Shepherd led the impaired capacity to consent framework. I co-led the socioeconomic disadvantage framework with Fran Shepherd from the University of Sheffield. And at the moment, we're working to try and get funding for an LGBTQIA+ framework. Now, we understand that they're multiplying. You know, we've left them unattended, we've fed them after midnight, and the frameworks are now multiplying. So what we are doing as well is working with a fantastic PhD student. She is remote, based in London, and enrolled at the University of Aberdeen. And her supervisory team are Sean, myself, Vicky, and Fran. So everyone who's been involved in these frameworks, and she's going to pull those together with intersectionality in mind. So, what is a framework? Essentially, it looks very, very simple on the surface, and then we lure you in, and it suddenly gets difficult. So we start with these 4 key questions. 1, who should my trial results apply to? 2, are the groups identified in question 1 likely to respond to the treatment in different ways? And usually we mean here cultural factors rather than genetic factors, that kind of thing. We're more of a socio-demographic approach, because we know that lots of people, we're not looking at genetics. Some people, of course, we are, but lots of people, it's more of a cultural and acceptability sort of problem of the trial and the intervention. And then number 3, will my trial intervention and or comparator make it harder for any of the groups identified in question 1 to engage with the intervention and or comparator? So we need to know, it could be that the intervention is an issue. That doesn't mean that we can't go ahead with the trial. It just means that we need to be aware of that before we start. And then number 4, will the way I have planned and designed my trial make it harder for any of the groups identified in question 1 to consider taking part? So along with these 4 questions that on the surface, it's just a couple of sentences that, maybe you could jot something down. Behind those, we have worksheets that go along with them so that we split the trial apart. It's almost like the myth of the British cycling thing that Dave Brailsford did. He didn't actually do it, spoiler alert, but he basically, the myth is that he pulled apart the trials team, pulled apart the cycling team, pulled apart the bike, and trying to make marginal gains at every stage. And that was how we then went on as a country to win multiple gold medals for the UK. So that's what we're trying to do with trials. We're trying to pull them apart, look at any part of it that might need a bit of cleaning, a bit of oiling, a bit of taking out the exclusion, and then putting it back together to try and make the whole thing more applicable and appropriate for the vast majority of members of our society. So these frameworks, it's really important that we do them at the before stage, so before you have problems, essentially. And I know that lots of people will come to me and go, I know you said I should have done it before, but now I'm having problems. I didn't do it before. Please can you help? And they are still useful at that point. To get the maximum use out of them, we want you to do them before the grant application goes in, essentially. You do them just after the grant application has been awarded, the grant's been awarded, that's fine, but what we want is to basically be able to influence the budget and where that budget goes. So you can do it right at the planning stage with a team approach. So you should have your research nurses in that conversation, participants that might be eligible for the trial in that conversation, clinicians, trial methodologists, statisticians, people that might be recruiting for the trial, people that would be tasked with trying to retain participants. You want everyone's voice in that room, whether it's virtual or not, and to try and contribute to really ironing out the little niggles that you will find that you only find later down the line when suddenly your recruitment is not going very well and your retention is really struggling. So with these things in mind, we know that this first question here, who should my trial results apply to? We know that's quite tricky to answer, because it's very easy to just knee-jerk it and go, well, everyone, or everyone with this disease. But who are the people with the disease? How do you decide what is representative for your trial participant population? And that's where the STRIDE project comes in. So the STRIDE project is one of those acronyms that is kind of an acronym, but not massively. So it's supporting recruitment and retention improvements for diverse ethnicities. So you'll see there's bits of capitalisation in that sentence and not to get to the STRIDE project. And the focus of this really was on who should your results apply to. So what we did was we started with those ethnicity frameworks because we know that we're sort of they give enough information for us to then have a starting point for, okay, what do we do next? So I was the person tasked with doing those 23 additional include ethnicity frameworks. 23 because we already had 7 on our website, so we wanted a decent chunk of 30 that people could then go and look at. So we decided that we would complete the ethnicity frameworks for what we termed core disease areas and edge cases. So core disease areas were cardiovascular disease, diabetes, mental health, and cancer. So we tried to make sure that we had a few different types and different sort of facets of each of those disease areas represented within those populations. So within mental health, we included depression and anxiety in various groups, but also schizophrenia and psychosis as well, because we wanted to get various ideas of what mental health was. In cancer, we included breast cancer, colorectal cancer, and prostate cancer. Diabetes, we had gestational diabetes, type 1 and type 2. Cardiovascular disease, we had stroke, we had high blood pressure, heart attacks, I think a couple more. Cardiovascular disease was the sort of funky area, as you can imagine, because it's a broad disease area. And then the edge cases came in because we wanted, well, we were conscious because a lot of the conversations that we've had with people around the ethnicity frameworks, they sort of say, well, it doesn't necessarily work for my area, my niche. It's quite hard to work it for my niche. So we wanted to prove that it was actually doable for everyone. So we were giving ourselves our own evidence to say, actually, it's not that difficult for your area. It might be tricky, but it's doable. So we included smoking cessation, IVF, and then a maternal health study as well. So the first step of that project was completing these ethnicity frameworks. We then did thematic analysis of the framework content to find common challenges. We ran expert panels to discuss trial design for each of those disease areas that all included patients and members of the public. And then we also had qualitative interviews. This was right before I left Aberdeen. Qualitative interviews with members of the public to go through ideas on recruitment and retention that would fit in with what we'd learned from those frameworks. So these are the lessons that we pulled together from mostly the panels, but also the sort of thematic analysis as well. So who stands to benefit most? What do you need to do? Who needs to be part of your process? Things we learned. So trial teams need to be more diverse. I think we all know that, but it really does make a huge difference. It makes a massive difference to the participants that are potentially being recruited. It means that they can see each other, see their own communities, and they have an area of safety within that interaction. Often it means that there are language barriers are reduced because people in their own communities can speak their own sort of language. And by that I don't necessarily mean English, Spanish, Bengali. I mean also the sort of the slang and the dialects that come from various communities. We need to include people from diverse ethnic communities with lived experiences of the condition within those panel discussions that we have to figure out who needs to be involved. Discussions need time, so we allotted 2-hour sessions for each of those panels, and most of them went off into another 2-hour session afterwards. And it was really getting to the nitty-gritty of who has this disease, what was the experience like. And you need to allow that time to allow people to share their stories, share their experiences, and often share their trauma as well. And obviously, sort of springing into that, so data on prevalence, severity, and progression is really important. Some cases just don't have that. We don't have data collection that allows for that to happen. So if you don't have any data on prevalence, severity, and progression with ethnicity in mind, you go with the most recent local data that you have. So making sure that you are choosing trial sites with ethnicity in mind to ensure that you're not just going to the leafy suburbs of middle-class Scotland or England and then being shocked that you only get the leafy suburbs of middle-class Scotland or England. Consider oversampling some groups. So we had a bit of a conversation around the term of oversampling. And often it wasn't really oversampling, it was more reflective sampling. So we know that lots of the trials that we've done so far in the world have been with white majority populations. It's not necessarily oversampling then to recruit non-white minority populations to sort of supplement that data. And the thing that will make most people cringe is don't think about how to recruit and retain people at this point. You just need to know who needs to be there, who needs to be in your trial sample with ethnicity in mind. Don't think about how to recruit and retain them. That is a future you problem. And that's where those frameworks come in to support how you do that, essentially. So very quickly, some tips from Stride. And these were mostly from the framework analysis, but also from the interviews that I did at the end of my time in Aberdeen. So the historical abuse and legacy of mistrust is still rife, and rightly so. In some cases, it's not a legacy, it's a recent memory for people. things like when the COVID vaccine was coming out and we were talking about Pfizer, the Pfizer vaccine, there was huge amounts of discomfort and worry, fear in the Nigerian community in the UK because there's been issues with what Pfizer had done within Nigeria. So even just labelling it as a Pfizer vaccine was troubling for these communities, and therefore they obviously didn't want to be taking part in any of the trials around that. I have mentioned earlier on language and cultural translation and interpretation. That cultural piece is really important because we need to make sure that we're, if you talk about diabetes, some communities will just refer to it as sugar. If you talk about anxiety, some communities don't actually have a word for that in their language. It's more of a physical symptom that they would talk about. So they might talk about a nervous tummy or a butterflies in their tummy sort of thing, rather than anxiety as we would sort of clinically talk about it. Use of alternative remedies before presentation is a significant thing that we will come across with lots of different diverse ethnicities, in that their interaction with the health system will not be their first point of call. So they will do things to try and solve things at home. Lots of us will do this, particularly if it's you're struggling to get a GP appointment or anything like that. You will try and do things at home to solve things first. And therefore, a lot of these communities, we're getting at a different stage of their presentation. We're not getting, oh, I've just found a lump and that's going to be an issue. It's, I've tried to do this, I've tried to do that, and suddenly I'm now 6 months down the track or a year down the track. And diet and lifestyle changes and family and societal views are very, very important to consider. If we're talking about nutrition and the sort of diabetes piece, a lot of the nutrition advice that was coming in that we were seeing and the interventions that were being tested were not culturally appropriate. They weren't going to fit into specific communities' lives. And for family and societal views, the stigma that lots of these diseases and conditions hold is real, and people don't want their privacy to be broken in any sense. We need to make sure that we're setting trials up with that in mind too. Intersectionality is always something that we need to consider. So if you have a very young person from a minoritized racial background, they're probably going to have a lot of the same views as somebody of the same age that is white Scottish or white British. When people get older, when their education is not necessarily of the same standard to this the majority population, that's where things really niggle. So it's trying to unpick the intersectionality as well as understanding that ethnic diversity is really important. Stereotyping leads to gatekeeping. So that was one of the biggest things that comes out in that if we stereotype, we just don't get people involved. You look at someone and you go, I don't know if their English is going to be particularly great to get this conversation going. That's going to be a faff with a translator and da-da-da. Ask them the question. It might be that they want to take part. Somebody is frail, you still need to ask them if they're going to take part. This stereotyping of, I'll put a decision in before you can, is really damaging for diverse and inclusive research. And then your recruitment routes, if everything goes through the same types of recruitment routes, so the health system, for example, if anything's going through the NHS, not everyone is going to use the NHS in the same way. So we need to try and think about how we can diversify your recruitment routes to try and hedge your bets a little better, not put all your chickens in one basket, your eggs in one basket, they won't all turn to chickens, and try and get diverse methods so that people can then engage based on where they think or where they, the contacts that they make throughout their own communities and who they trust. So just very quick thank you and acknowledgements. STRIDE was funded by the Chief Scientist Office. We also had a lot of support from the NIHR Include Steering Group, and the NIHR Include Ethnicity Framework was sort of a spin out of that Include Steering Group, so we thank them wholeheartedly. Trial panel participants gave up an awful lot of their time to come and work with us. We did pay participants, but they still invested their time and expertise. And Trial for Geography, which is led by Professor Sean Trueweek, who did contribute and lead a lot of this work. So yeah, thank you very much.
Thank you, and thank you for considering.
Okay, yeah, all good. Okay, so I'm going to talk a little bit about share, and I'll be very brief. Okay, so why share? So we've got a paradox here. Researchers have difficulty getting in touch with people who are interested in taking part in research, and we know there are lots of patients out there who would like to take part in research who don't know about it. So that's why we invented SHARE. So it's a register of people aged 11 or over who live in Scotland who are interested in helping with research. They've given permission to use their NHS databases to establish whether or not they're eligible for research. And most have also allowed retention of blood, which is picked up at routine assessments, to be used for genetic research as well. So we have over 300,000 people who are gagging to help you with their research. The biggest complaint we have from people on the SHARE register is that we do not ask them enough to take part in research. Most people give us permission for the spare blood. We've got 170,000 samples from 100,000 people in the Biobank. We will provide a free feasibility service. So in other words, if you've got a research project you think we can help you with, you just come along and we will tell you, we'll check out the numbers for you and let you know whether or not we think we'll be able to help you with it. And we'll help you with putting the right sorts of codes in order to find that out. So how representative is SHARE? So we've just heard about this, is SHARE a representative body? And a lot of people working in the field say, oh, it's fine, but you don't look after the sort of patients I look after. They won't volunteer for something like SHARE. So this is what our age distribution is like. And as you can see here, although it is largely weighed or heavily weighted in the older age groups, where in fact where most illnesses are and which most people we've got most interest in from researchers, we do have lots of people who are younger as well. The age distribution, for example, in UK Biobank is much, much worse than it is in SHARE. So if we look at ethnic minorities, you can see this 4% of Scotland's belongs to an ethnic minority. We have gone to a huge effort in SHARE, standing outside of mosques and temples, trying to recruit people into SHARE. And we actually have more than the national average of people from ethnic minorities in SHARE. If we look at deprivation, you can see that this is what Scotland looks like as a whole for deprivation, and this is what SHARE looks like. We have got everybody from the most deprived to the most wealthy in SHARE. So if you're looking for people with particular groups, you can do this. And we've done this. We have oversampled for some conditions. Dave Newby was struggling to get, he was finding the people who were volunteering through normal sort of methods were largely middle class. He specifically asked SHARE to search for people from postcodes that we knew were deprived areas. And we've been doing that for him. So if you look again, it's a poor old Biobank, but you'll find that Biobank, for example, does not have hardly anybody in deprived populations. And we're all over Scotland. Admittedly, we're in the areas naturally where most population is, but in fact, we have participants in the whole of Scotland there. So if you want to, we just updated the website just in the last few months, and it's we'd like you to have a look at that and give us your feedback on it. And if there's anything you'd like us to change, we'll consider changing it. There's an interactive tool if you're a researcher and you want to find out whether you think SHARE might be able to help. It's really good. It tells you all of the different main categories of illness there, the numbers we have in each of these, and also of medications as well. And the medications are very accurate. Some of these conditions are not well coded. So for example, if you were looking for patients with migraine, GPs are not very good at coding migraine, but you could look for anti-migraine drugs and you would find these patients. So by using a mixture of conditions and medications, we can find just about anybody. And you can actually find out how many you want in your area. So, for example, this is congestive cardiac failure, and these are the numbers that we have with these conditions in GGC and Tayside and Lothian. So, and you can do that just on the website yourself. So what do researchers have to do? You do SHARE, they just have to fill in a form. It is the easiest thing to fill in. Now, if you're just doing a feasibility study, it's very, very simple. You just have to give us more or less your question, give us some idea of the type of people you want to look at, and we'll look those up for you. If it's been approved, you've got your money for the study, then we require these other things. I'm not going to run through them. They're all the obvious sort of things you would expect any researcher to have before they embarked on any type of research. So what will SHARE deliver? If someone's a good fit and they're willing to participate, then we let you as researchers have that person's contact details, and we'll supply the contact details of the patients and also the best time and number to get in touch. And you know that these people are interested when they phone up. I'm not going to go through all of these. these are sort of projects that we've done in the past. We could send out a survey to 50,000 people in a couple of hours. We recruited 150 volunteers. This is incredible, to undergo an endoscopy. I mean, how many people would be willing to do that when they don't have anything wrong with it? So development of highly sensitive COVID antibody tests. So we were the only people in the country could do this. We had the blood samples from prior to COVID. So we knew these blood samples, these people had never been exposed to COVID. We were able to develop an antibody test, which was put into use very, very quickly during the COVID pandemic. And the Corona Genes Project, we hopes to understand the genetic basis of COVID. This is an example of what we did. You can see here, they were really beginning to tail off at recruitment until they joined SHARE, wham. And that's what happened as soon as SHARE sent out the information to the patients, and they all joined. So this is an example of, we talked about this earlier, some people have genetic have the wrong sort of genes to metabolize clopidogrel, which is the most widely used anti-stroke drug. And we did some work, Collins here, he was responsible for this, which showed quite definitely that people who carried this gene were more likely to die than people who didn't carry this gene. This work, along with other work in the field, has influenced policy now, and it's now recommended that people have a genetic test before they go on clopidogrel. So ongoing studies, I'm not going to go over them all. I'll talk about a few. So if we look at, you can see here's a variety of things from questionnaire studies to CTIMPs to genetic studies. Scott Hart 2, which I mentioned there earlier, is looking at risk factors for cardiovascular disease. Loads of people put on statins. If you're over the age of 65 like me, you would just about automatically put on a statin. Yet the vast majority of people do not need these drugs. They don't need them. And so we wanted to find out whether, in fact, scanning people to see if they've actually got atheroma will make a difference. You heard about Scott Hart 1 earlier today. So using SHARE is actually very, very cheap. So unfortunately, big problem we have is that people come to us too late. They've already tried the more traditional route for getting for recruiting patients, and they've spent all their money, and it's a bit more awkward then. But we will do our best to help out, and we have rescued loads of studies at the last minute. So we only ever recover costs. It's not a business, but if we have to send out letters to people, we have to pay the postage. We have to find a way of doing this. And as I say, we offer the feasibility for free. If you're thinking of doing research, come and speak to us, and we will tell you what it's going to cost before you put your grant application in. And we will stick by that generally, unless something changes. Finally, so I've mentioned that, always add SHARE as a potential recruitment source to protocols and IRIS applications if you can remember to do that. It may not be essential to do that, we're thinking in future, but it would be better if you did. Check out our website, and feedback's always welcome. So thank you very much. And that's it. Yep.
Thank you, Brian. We should have some time for questions, but maybe we'll lump them all the questions in at the end.
Sure.
And we'll go through the presentation. So next up is Lesley Cousland, who's a mental health nurse, and is going to tell us all about the ENRICH initiative, which is about supporting research in care homes. So thank you, Lesley.
Okay, thank you. This is ENRICH, Enabling Research in Care Homes, and this is our team. Obviously, care homes are a huge community with lots of knowledge and skills, but they're often underrepresented in research. So I'm just going to give you a whistle-stop tour to how we are trying to enable research in care homes. And if now, how does this work? Apparently it's press it one more time. Thank you.
This is just one of over 1,000 care homes in Scotland who are leading the way in research, supported by ENRICH Scotland, enabling research in care homes. We promote and support research in partnership with care homes across the country. We're working together towards the goal of improving the lives of residents, their families, and the dedicated staff who care for them. Research plays a crucial role in identifying best practices and putting them into place to provide the best possible care. By understanding the unique needs of care home residents and staff, we can make informed decisions that lead to positive change.
It's just about improving the quality of the residents, the staff and the relatives' journey through care. Just making it more accessible for people, finding out what works, what doesn't work, but it's just about involving everybody.
I came here just after Christmas. We enjoyed it. I wasn't looking forward to it, when my daughter's wedding. But it's been great.
I like it here. People are very friendly. Staff are good.
You get laugh with them, and you laugh us.
I think research is important for better quality of life of the residents, getting them to experience more things, getting relatives more involved, and finding out that residents like something that they didn't even know they were interested in. In my head, research in a care home would be just sitting, having a chat, having a cup of tea, having a cake.
Residents coming into here could be quite stressful, so you might want to know a bit of background about these residents, things they've done at home, their past hobbies, jobs that they used to do, all things that can help them settle into the care home as well.
The research I would like to see for the future is more around how we can make the transition from home to a care home setting a little bit better. To help us do research in care homes, it's just about communicating with us. We're very willing to take part in any research that you have going on. If we can help, we will.
As you can see, research in care homes is simple to take part in and makes positive change happen. There are opportunities for everyone, residents, families and staff. We at ENRICH Scotland will continue to work to make a lasting impact together.
Let's take you through quickly a SWOT analysis presentation. The main responsibility of the clinical studies officers is actually to build and maintain relationships with care home staff and their residents and their families. So we do that right from the outset. As soon as we hear of one of our care homes that want to register with ENRICH, we'll go along, meet with the care home managers, we'll get a blether with the staff as well, which is really, really nice. And I think that gains some trust with the care home staff. So we kind of know when research is coming through who's interested in what specific topics, so we can go directly out to them. We don't only build relationships with care home staff, we also build relationships with other key stakeholders. That's really important as well. So that includes Scottish Care, that includes our partnerships in local areas and other groups such as the Care Home Activity Network, and intergenerational working. So there's lots of options there. We will go out to any conferences, speak to anyone. We'll go to care home local meetings. We'll go to care home training. We're quite a flexible team, so we really like to get out and about and speak to people, especially in a face-to-face. And after the pandemic, the care homes have actually been really welcoming to that. So that makes a big difference in how we bring care homes on board. We also have our Rich Voices, that's Research and Care Homes Voices, and that's chaired by Dr. Rosie Ashworth. And that's really about co-production. She's very big on co-production, as co-production should be. But it's really at the early stages. They have an image gallery that they've taken images from the whole day we were at Wraith Manager, and hopefully we can use that to depict care home life in a more positive and perhaps a more up-to-date way. We've got all other groups as well that we use. We have opportunities for care home managers to come to come and get involved in research. We have the research forum for researchers to come together and talk about research, whether that's ongoing research or new research. And sometimes care home managers will come to that because often what researchers have in mind may not actually fit with care home life. So it's really good for them right at the start to get that feedback. We also have the Care Home Innovation Partnerships in Glasgow and Edinburgh. Again, that's another route for local researchers to work with local care homes. But our biggest strength is our team. As you saw at the beginning, there's quite a few of us, but some of us work for 2 hours in a week, some of us work for 2 days a week, and we're all based in each local, well, I was going to say local authority, but they're now partnership areas. But we cross boundaries, we're very good at helping out each other. I think the clinical studies officers have all got a nursing background, but we all come from very, very different backgrounds. So we share and we lean on each other when we need to. Next. Weaknesses, of course, there are weaknesses. Governance, more work is required to develop and streamline the ethics review process. I'm not a researcher, but I believe that's quite a difficult process. And this work is going on currently, and Irina McLean, who's here today from NRS, and also with ENRICH. So I would direct any questions to Irina. Thank goodness you're in the audience today. Capacity, it's never going to change. A high staff turnover. We also see a lot of managers change very, very frequently. So as clinical studies officers, that's part of our roles to try and keep up to date with that, go out and speak with new managers who may not have heard of ENRICH in the first instance. But also chronic staff shortages, recruitment and retention is really difficult just now in the care home sector. Diversity, we aim to promote rural communities to researchers. Often they haven't had the opportunity to participate in research. However, recently one of our co-chairs, Dr. Emma Law, was out in Shetland and met with a bunch of care home managers who were really excited to get involved. So they're all on board as well. So although there's a number of weaknesses, we've identified these and we're putting things in places to try and minimise that. Opportunities, there's loads of opportunities. Obviously, for care home staff, residents and families to gain new knowledge and skills. It's well documented about the benefits of taking part in research, so I really don't need to go into that. Share experiences. Research methods are already out there that will fit quite well for researchers to go into care homes in a social context rather than a clinical context and use these tools. I'm a nurse. I know that research brings potential to improve care and to influence future practice. It would be really good if we could influence future practice for the wider sector, not just for individual care homes. Threats, well, yep, there's threats. Repetition. I think during the pandemic, there was lots of using online surveys and they're a wee bit fed up of online surveys. So luckily we've got researchers who have been listening to that, and we've recently had a study going on with Napier University that actually went out to care homes, spoke to care home staff over a 24/7 period. They were there on the night shift as well, and the care homes are saying to us they would like researchers to come out to them, get to know them, and be a wee bit more flexible. And they may work 9 to 5, but as I say, care homes don't work 9 to 5. This links with maintaining momentum as well. Research can be lengthy, takes a long time, and care homes want something back in return, but they want something that can quickly and easily use. Many care home staff won't read a research paper in an academic journal. What they want there and then is something back, and something that maybe links to their standards so that they can see exactly where they can pop that into their practice. The pandemic was really hard. It's changed a lot of things in care homes, but actually post-pandemic, I was speaking to a manager last week who said, Lesley, the pandemic was really hard, but now it's even harder. The cost of living, staff leaving, recruitment and retention, paying conditions. So it's really hard for them, and I don't think it's going to be ever it's always going to be difficult, but we have to work around that. And funding. Our funding is currently renewed annually. We are funded by the Chief Scientist's Office, and we have been for the last, I think this will be our 3rd year. And this creates a certain level of anxiety about how we can move forward in the long term. So that's a whistle-stop tour of ENRICH Scotland and how we enable research in care homes.
Thank you. And lastly, we've got Dr. Pamela Dixon, who's the NRS Paediatrics Network Manager, who will tell us about her work. I think you just move on. Yeah. Try that. Is that you?
Okay, so I'm not sure how we are for time, so
You're fine.
we are okay.
Yeah.
But I'm going to really concentrate towards the end of the presentation, because that's where we look at case studies, and I think that probably brings things into reality a wee bit more for everybody. So what I was planning to speak to you about today is I was going to give you an introduction to the network, but I'm going to quick past that. What we mean by decentralised trials, I think, is there anyone in this room who doesn't know what a decentralised trial is? Okay, so we can probably push past that as well. And then why paediatrics are different, because I think that's really important. It's why do we have to come to this with a different perspective? Some of the case examples of what's worked well and why, and then really what's important to us is some recommendations for the future. So our research network, we're one of the many topic specific networks. We're funded by the Chief Scientist's Office since 2008. and it's to promote and facilitate high quality research in children's healthcare. So it's about medicines, but it's also about the best prescribing practice, about existing medicines, and then also some of your basic science looking at biological mechanisms. And this is the infrastructure of our network. Anybody who wants to know who's who, this slide will be available, so I'm just going to go past that. So why paediatrics? Why is it different? Well, children, they're not little adults, and nor are they bigger babies. There's many conditions that begin in childhood, so either from their prem baby, or it's a genetic condition, a metabolic condition. So this happens with them throughout their whole lifetime. So we have to look at the different stages of development. We have to look at maybe how their organs develop and how that means they then metabolize their medication, different from adults or at different stages of development. And one thing that's really important is also a changing level of involvement in the decisions around their healthcare. So whether or not they want to participate in research or whether or not they want to participate in a particular type of healthcare, that is a sliding scale of responsibility. And also, we're not working with children as an individual, we're working with a whole family. And as you say, it's not the child that's sick, it's actually the family that has a sick child. So therefore, you have to look at how you can incorporate that family and their needs. Decentralised trials, there was a rapid change in the whole attitude towards decentralised trials with COVID. In 2019, when they asked some CROs and some pharma companies what percentage of their activities would be virtual, they sort of said 38%, and a year after COVID, that went up to 100%, and then and 89% for what percentage would be carried out in patients' homes. So there's a big change, and the main driver that we see for that is people say, well, it makes research more accessible to a wider demographic of participants who would otherwise not take part in site-based research. We've got some caveats on that when it comes to paediatrics. Those sudden changes happened almost overnight due to COVID, and so clinical care changed all of a sudden. Things that became acceptable were video consultations, home administration of medicines that would never have been considered before in paediatrics, and mums or dads giving injections to their children at home, with a lot more home visits by nurses and the use of hubs. However, that was also mirrored by research. So all of a sudden, our CRF closed. Outpatient departments didn't want the footfall through the hospital, and so we also had to make changes to research and how that was delivered. So again, video consultations, all of a sudden electronic recording of e-consent and assent, that would previously had been a huge stumbling block for us to get governance approval for that. Home administration of IMP, and also self-assessment, much more self-assessment and reporting of outcomes. So during lockdown, what happened, one study overnight was that the Ustakid trial, these were patients who were newly diagnosed type 1, aged 12 to 18, and they were at that time coming into the CRF every 6 weeks for subcutaneous injections of ustekinumab every 6 weeks. Overnight there was lockdown, they couldn't come into the hospital, and also the nurses couldn't go into their homes because that wasn't allowed either. So they had to sort of deal with how they would make changes. So it went to, the parents were supported in the preparation of the injection. So that was one of the big stumbling blocks for that one. It's not a pre-filled syringe, they actually had to be supported in how they made up that injection that administered it. And they had video calls from the research nurses in supporting that. And the lessons that we learned from that were, one, that actually it was possible with the correct support and from the right people, but it was also very much dependent on the family. So not every family found that an easy transition. But also, decentralised trials are basically here to stay. And all of a sudden, the governance around it became a lot more flexible. So we had guidance issued by the MHRA, European Medicines Agency, the FDA. So globally, decentralised trials were here to stay. What do we have to consider from a paediatric perspective? Well, the overall arching is really the family, but I'll look in detail at some of these considerations. With this, I'll put in some case studies to sort of try and highlight why they're particularly specific to paediatrics. So the location, so it could be in the hospital or the clinical research facility. We've invested huge amounts of money in our children's hospitals to make them child and family friendly. They're beautiful. If you go across the road there to the children's hospital, this is the entrance. It's a fantastic facility. We have additional services, wraparound services. You've got the expertise there, specific procedures. You've got play therapy. You've got distraction. You have to consider the distance from home. For some families, we're in Glasgow here, there might be families that are recruited from the Western Isles. They've got the time that it takes for them to get here, their travel time and their expenses. And also, can you provide flexibility for the whole family, not just the one child, around their school work and around work? The location, if it's the home, well, that would be very much dependent on the procedure. It could be that it's parent or patient directed. It could be the research team that's going in. It could be the contractor. Something we see a lot more in adults is the contractor service provider. However, the PI still has oversight, and they've got to be aware or have oversight of the safety and responsibility for that patient. And if you're contracting that out to a third party, you don't know them as well as you know your own research team or your own clinical team, and that is a concern. There's the relationships with family. If it's a child who's had a chronic condition and they have had a needle phobia, and the team have worked very, very sort of closely with that family to overcome that, do they then want somebody else going in who doesn't have that expertise and ruining all that sort of taking that pathway right back to the very beginning? We've also got to look at things like the preference for that family might change. What's suitable this month might not be suitable next month. We need to have that flexibility. There might not be privacy in the home. There can be other family members there. There might be a granny who lives there with dementia who's maybe be quite confused at a research nurse coming into the home. These are the type of things that we have to consider. And we have to also look at the safety of lone working. So we talk about decentralised trials, going back to that earlier slide, increasing the ability to recruit more patients. But by increasing the geographical diversity, we've also got the potential to reduce social diversity. The Royal College of Paediatrics says 24% of children in Scotland live in poverty. And as we've heard earlier this morning, there's very established links between poverty and chronic disease. And if we see, as we're increasingly seeing, protocols coming through where the home visits are mandatory because everyone's selling us this narrative that it's better and it's more inclusive, we're actually excluding families that don't want somebody coming into their home. Some families want to come into the CRF. They get travel expenses, they get maybe away from the circumstances they're living in, they feel that it's maybe a safer environment for the other children. They might be in an accommodation situation where it's temporary housing, or we've actually had instances where a family, the mum had phoned up and said, we're moving into temporary accommodation, we're losing our rental, I don't know how I'm going to manage to stay on this study. These are things that we have to be considerate of, and I think sometimes, very often, what comes down from our industry partners and our clinical research organisations is they're actually so far removed from living in that situation themselves that it's not foremost in their mind when they're creating those protocols. Some families are very concerned about somebody official turning up at their doorstep. Are they being judgmental? Or who are they reporting back to? Is there a safe space for the storage of the medicines? And of course, we've heard about digital inequity as well. So one of the examples we have was a study of Breathing Together. It's a 5-year research and engagement programme, and these are families that were recruited pre-COVID when mums were pregnant in 2018. And then it was stopped during COVID, and then it restarted again. And when the nurses approached the families, this one was based this example is based in Grampian. Out of the 92 families, 54 still opted to come into the CRF because they said it was child friendly and the different reasons that I've included there. And then some of them wanted them to come home because they had a new baby, or they were worried about coming into the hospital because of COVID, or they didn't have transport. So it really was very family dependent. The feedback from the nurses was that giving them this option of coming in or them going into the family home, it did increase retention, but it was very much a family and a parent decision. what they had to do was to complete a lone working risk assessment for going into those houses. And they felt it was also very important that they had previous knowledge of those families, because there's things to consider. It might even be things like they have dogs in that house that you wouldn't want to particularly go into the house with. But by knowing the family, knowing where they stay, they could do a risk assessment as do you want to go on your own or do you want to go with another staff member. But of course then that's got impact on our costings. It's got impact on our staff resource. The procedures at home, it will very much again procedure dependent. If we, for example, blood pressure in a renal study, that has to be much more accurate and precise than blood pressure in a different condition. So again, the PI has to have oversight and confidence in that assessment. I've mentioned contract providers, are they paediatric trained? I mentioned phlebotomy again. And then things like telemedicine. There's a migraine study that's available at the moment, or that we're involved in at the moment, and it has something called the Columbia Suicide Assessment Scale. Is that something that you should be doing over the telephone or over a video consultation with the teenager? And are you actually getting useful information back? Because they'll just say everything's fine, because that's really what they're going to say in that situation. So is it really an accurate assessment? Patient-reported outcomes. Traditionally, it was always a paper diary. Some of those could be pages and pages long, but now because all of a sudden it's in an e-consultation, or they put a bit of gamification in, sometimes the expectations of the sponsors or of the CROs are just too much. And we've had incidences where families have been very keen to participate in a study. When they actually saw the amount of time and what was expected of them, they changed their mind, because they don't need that. They've got app fatigue. I mean, how many people have like downloaded a step counter or a dietary thing or whatever, and after 4 weeks you stop doing it. You know, we get fed up doing things, and it has to be calibrated for children. Things like wearables, they have to be able to go to the pool, play sport, whatever it is that they want to do. A case, Prader-Willi syndrome. These are children who have got difficulties, learning difficulties. They've also got mobility issues. It was a decentralised model, so this was an extension of a previous trial that was already ongoing, and the new sort of protocol that came out had a lot more decentralised component. This actually worked really well for those families, because the children have daycare facilities that they go to and they really enjoy. It was changed to coming into the CRF for just their consent and then the 3 monthly appointments. There were some difficulties from the nurse's perspective in things like assessing edema and hirsutism over a video consultation when somebody's camera is not that good. But you know, there was ways working around that. If they had concerns, they brought the families in. Treat study is another one. I'll just run past that, because again, it's just the same type of thing that we learned from it. Consent and assent. If it's an adult process, it might work very well, but if it's children, it needs to be made a bit more dynamic. There's no point trying to replicate the wet ink system over video. It has to be really embraced and taken on board. So the final slide, our recommendations. There must be flexibility in the protocol, and it really needs to be patient and parent specific. We talk about GIRFEC when it comes to education and health and social care. We need to do GIRFEC in research as well. We shouldn't make assumptions that a home visit increases diversity. We should, every protocol that's been written, consult with the PI, consult with the research nurses, and consult with the patients. They're the people that are going to deliver that research. If we're going to have staff time for home visits, it needs to be costed and resourced. PROs, are they necessary or are they burdensome? And IMP, will to look at safety. And just thank you to all the research nurses, some of whom are here in the audience today, who gave us their experiences about decentralised trials.
So
So now we're talking about stuff.
yeah, we're kind of doing okay for time.
Yeah.
We're back on schedule, so I think it'd be good, you know, if folk want to ask maybe one or two questions, but I do want them to be all be
Yeah.
first in the lunch queue. So, any questions for any of the speakers?
Just to say, sorry, that just for the recording, and I'll just go around with the mic so that it can be picked up.
Go for it.
I'll ask one. So, what we heard, and it's a shame Heidi's couldn't stay on, but the other talks were all about resources available for researchers. But I know that one of my responsibilities is one of the CSO research committees that researchers sometimes don't take time to use the resources that are available. So I just kind of wonder, really aimed at all three speakers, how can you encourage researchers to make use of the excellent resources and expertise that you provide?
I think we just have to make sure that everybody knows about them, and I think that's the most important thing. And I think actually CSOs are one of this too, that whenever people apply for something or apply for a grant, it should be made obvious that there are resources out there. You should consider these resources, and maybe when, for example, you're assessing a grant, you're considering giving them money for it, you should maybe be saying, actually, there might be a better way of recruiting people than this, and you should consider that. So I think it's a real role for a CSO there.
Yeah, I think I'd just back that up in the fact that, ask the people who are going to be doing the research, ask the patients and ask the research nurses, because they're the ones that they'll have done something very similar before, and they can tell you the hurdles before they start. So I think the resources are all there. Just when people tick that PPI box or they tick that feasibility box, I think the question is for you to go back to them and say, what PPI have you done? What impact did it make? Who did you listen to, and what changes did you make?
Yeah, I knew that question was going to come back.
Anyone else?
Sorry, just to carry on that one. Almost the assessment of the grant is probably too late.
Yeah.
I think it should, maybe we need to look at how guidelines, the guidelines for applicants and things like that are actually, see if there's somewhere where we can actually optimise that sort of knowledge transfer. Yeah.
I suppose from my point of view, there's always a challenge. Is that the word? That accessing that PPI support before you have the grant is, if there's financial implications and so on, that's actually can be quite difficult. And to understand maybe how researchers can use the networks before, at such a proof of concept or workup stage, and understanding how that works, I think just getting the word out there would be really helpful.
And sure, we'll recruit for PPI. So if people who are interested in setting up a PPI group, we will recruit for that. For free, isn't it?
So if you've got anyone contacts one of the networks, then they're more than happy to provide feedback. There's no charge for that, because you're benefiting Scottish patients. And the same with the PPI groups, where you're on a young person's advocacy group. I know that other networks run PPI groups as well. If that's benefiting Scottish patients in the long term, then we wouldn't be charging for that service at that time.
Okay, shall we leave it there then? Just thank you to all the presenters today, and hope you enjoyed the morning, and I hope you enjoy lunch now and the afternoon session. So thank you.
Thank you.